Welcome back to the deep dive. Today we're doing something a little different. Usually we look at big systems economics, tech, history.
Yeah.
But today we're looking at architecture. Specifically, what might be the most complex, high-stakes piece of engineering in the entire human body.
It sounds like a bold claim, but I think it absolutely holds up. We're talking about a space that's no bigger than a golf ball.
Okay.
And it houses our ability to hear, our ability to balance, and maybe most importantly, our ability to show human emotion.
And you'd just miss it if you looked at one of those plastic skeletons in a classroom. We're talking about the temporal bone.
Yeah.
From the outside, it just looks like a curved plate on the side of the skull. But the source material you brought in, these are high-level surgical notes, anatomical classifications. They paint a very, very different picture.
They really do. If you were to slice that bone open, it's not solid. It's a labyrinth. It's a fortress with, hidden tunnels, air pockets, sliding doors.
And a very important tenet,
A VIP tenant that I think causes more stress for surgeons than almost anything else.
the facial nerve.
The facial nerve, the wire that literally controls your face.
So our mission today is to decode this thing. We need to understand how this bone is built, why it sometimes fails to build correctly, and then trace the path of that nerve. And I have to say, looking at the measurements in these notes, it is a miracle that nerve survives at all.
It really is a game of millimeters.
So let's start with the foundation. The temporal bone itself, I think most people, myself included, assume a skull bone is just a bone, one single piece.
Right.
But the notes highlight this is more of a fusion job.
It is. A good way to think of it is like a house built by 4 different contractors who didn't really look at each other's blueprints. Anatomically, you've got 4 distinct parts that fuse together.
Okay, what are they?
You've got squamous, the petrous, the tympanic, and the mastoid parts.
All right, help me visualize these. Squamous, that usually means flat or scale-like, right?
Exactly. The squamous part is that thin, flat plate on the side of your head above the ear. That's the siding on the house. But then you get to the petrous part, and petros is Greek for rock.
Peter, the rock.
Precisely. The petrous portion is pyramid-shaped. It wedges deep into the base of the skull, and it is rock hard. I mean, it's one of the densest bones in the body.
That's a bangle.
That's the vault. It's where the delicate hearing and balance organs are locked away safely.
Okay, and then you have the mastoid, which is that bubbly part behind the ear, and the tympanic, which holds the eardrum. But here's the stat from the notes that just floored me. The development. It says there are 21 different ossification centers.
21.
It seems excessive.
It's incredibly complex. So an ossification center is where cartilage turns into bone. In the embryo, you have 21 separate islands of bone, all growing outward, trying to meet up and fuse into one structure.
And 14 of those are just for the petrous part.
14 just for that rock hard vault.
So with 21 different moving parts trying to click together, I mean, the margin for error must be huge.
It is, and it creates these internal walls or partitions that can actually persist into adulthood. The most famous one, the one mentioned all over the surgical texts, is corner septum.
I saw that in bold. Corner septum. It sounds like a bad architectural feature, like a pillar in the middle of a room.
It's a surgeon's nightmare. So remember we said the bone fuses from different parts?
Yeah.
Corner septum is the leftover wall between the squamous part and the petrous part. It's an embryologic junction.
Why is that a nightmare? It's just a wall of bone, isn't it?
Okay, picture this. You're a surgeon. You're drilling into the mastoid bone behind the ear to clear out an infection. You are looking for the antrum, the main central air cavity that's deep inside.
Right.
You drill down and you hit a solid wall of bone.
You'd think you've hit the bottom.
You think you've reached the medial wall. You think, okay, I cleaned it all out. But you haven't.
You've just hit corner septum.
You've hit a false bottom. And the real disease, the infection, is hiding just on the other side of that wall, deeper in the petrous bone.
So if you don't know that false bottom can exist, you close up the patient with the infection still inside.
Exactly. It separates the superficial air cells from the deep ones. If you don't break through it, you haven't finished the job.
That is wild. It's literally a hidden room problem. So if I'm a surgeon, how do I even know where to start drilling? I can't just bore holes in someone's head.
No.
The notes mention a specific landmark, Mesuan's triangle.
Also known as the fossa mastoidea. It is the X marks the spot for any kind of ear surgery.
Can we find this on ourselves?
You can actually put your finger right behind the top of your ear. You'll feel a ridge of bone running backward.
Okay, I feel that.
That's the temporal line. That's the top border of the triangle. Now slide your finger down to the back edge of your ear canal opening.
Got it.
That's the front border. Mesuan's triangle is right there, in that little depression between the ridge and the canal.
And if I drill there,
If you drill there and you stay within the lines, you're safe. You go about 15 millimeters deep, and you should hit the antrum, that central air space.
and if I miss,
Well, if you go too high, you're in the middle cranial fossa, you're hitting the dura of the brain.
Oh.
If you go too far back, you hit the sigmoid sinus, which is a massive vein. So yeah, staying in the triangle is pretty important.
it sounds like a very high-stakes operation. But speaking of high stakes, there was a warning in the text that really stood out. It was about the difference between operating on an adult and an infant.
Oh, this is critical. Anatomically, they're not just smaller versions of adults. They are shaped differently.
The notes say the mastoid tip is undeveloped.
That's right. On you or me, if you feel behind your earlobe, there's a bony bump pointing down. That's the mastoid tip. It acts as a shield. The facial nerve exits the skull underneath that tip, so it's deep and protected.
But a baby doesn't have that bump.
No. The mastoid tip hasn't grown yet. So the stylomastoid foramen, the hole where the nerve actually comes out, is much more lateral. It's superficial.
So it's basically right under the skin.
It is. It's right under the skin behind the ear.
So a surgeon making a standard incision behind a baby's ear.
Could cut right through the facial nerve before they even realize they're past the skin.
That's a terrifying thought. You go in to fix an ear, and you paralyze the child's face because the shield just hasn't grown in yet.
And that's exactly why pediatric anatomy is its own specialty. You can't rely on adult landmarks.
Let's pivot to something else that defines this bone. We keep talking about air cells. When I think of bone, I think of, a solid, white, dense thing. But the mastoid is supposed to be fluffy.
Ideally, yes. It should look like a honeycomb. We call it pneumatization. The bone is filled with these little air pockets, all lined with a mucous membrane.
But not everyone has this honeycomb structure, do they? The notes imply there's a huge debate about why some people have hollow bones and others have solid rock.
This is one of the classic debates in otology. It's basically nature versus nurture, but for your ear bones.
Let's break down the nurture side first, the environmental argument. The notes list a guy named Tumarkin.
Tumarkin was, I think, a physicist at heart. He proposed the vacuum theory. He said, look, if a kid has a blocked eustachian tube, maybe from big adenoids or chronic colds, air can't get into the middle ear.
And that creates a vacuum.
Exactly. And that negative pressure prevents the air cells from ever expanding. The bone stays collapsed and dense because the air never pushed it open from the inside.
That makes a lot of sense. But then you have Whitmack's hypothesis, and this one feels a bit more visceral. He's talking about something happening at birth.
Whitmack focused on the lining, the mucosa. He argued that the bone will only pneumatize or get airy if that mucous membrane is healthy. But, he asked, what if amniotic fluid gets into the ear during birth?
Or meconium.
Right, the baby's first stool.
Yeah.
If that material gets forced up the eustachian tube during labor and enters the middle ear, it causes a huge foreign body reaction, inflammation.
So the lining of the ear gets scarred.
It gets scarred and thickened. And because it's damaged, it can't invade the bone to create those air cells. So, according to Whitmack, a single event, a bad swallow of meconium at birth, could determine the internal architecture of your skull for life.
That's fascinating. It's a butterfly effect moment. One bad breath at birth, and 40 years later you have a sclerotic mastoid.
That's the theory. But then you have the nature crowd, the geneticists, like Diamond and Stern.
And they just say, nope, it's all heredity.
Pretty much. They looked at families and said, if your parents have solid mastoids, you're going to have solid mastoids. Doesn't matter how many ear infections you had, it's just your genetic blueprint.
And then Graham and Brackman took it even further, connecting it to the size of the whole head.
They did. They noted the scaling effect. If you look at patients with acromegaly, where bones grow massive, they have huge, super aerated mastoid systems.
And people with microcephaly.
Small heads, small mastoids, very little air. So they argue it's just a function of overall bone growth.
So after all these theories, where do we land? How do we actually classify patients in the real world?
In practice, we keep it simple. We group them into 3 types. About 80% of people are what we call cellular.
Okay.
They have that classic honeycomb, well-developed air cells.
And the ones who don't.
That's the sclerotic group, about 20%. They have a small antrum and mostly solid, dense bone.
And there was a third, rare one, diploid.
Very rare, less than 1%. That's where the bone is actually filled with bone marrow, red marrow instead of air.
Okay, so we built the house, we've got the temporal bone, the false walls, the air pockets, now we have to talk about the tenant.
Yes, the facial nerve.
You called it the diva of the cranial nerves.
I did.
Why a diva?
Because it is incredibly high maintenance,
Correct.
it takes a ridiculously convoluted path, and if you even look at it the wrong way, it shuts down.
The notes list its job description. We know facial expression, smiling, frowning, blinking, but it does more than just that.
Oh yeah, it's a mixed nerve, not just a motor nerve. It carries taste sensation from the front 2/3 of your tongue. It controls your lacrimal glands, so your tears, and your salivary glands.
So if you damage this nerve, it's not just a frozen face. You might lose taste, have a dry eye, a dry mouth.
It's a sensory deprivation issue just as much as it is a cosmetic one.
Let's trace the path. The outline calls this the obstacle course. And honestly, looking at the anatomy, it really does look like a design flaw. It starts at the brainstem.
Right, at the pons, and right away it does this loop-de-loop around the nucleus of the 6th cranial nerve. Then it shoots out across the cerebellopontine angle, the CPA.
And it's traveling with the hearing nerve at this point, the 8th nerve.
They're travel buddies. They enter the internal auditory canal, the IAC, together. That's a tunnel about 10 millimeters long.
Okay, so far so good. But then the hearing nerve stops, and the facial nerve gets its own private tunnel, the fallopian canal. And this brings us to the first danger zone, the labyrinthine segment.
This is the bottleneck. I mean, literally. It's the shortest segment, only about 4 millimeters long, but it is the narrowest point in the entire journey.
How narrow?
The diameter of the canal here is only about 0.68 millimeters.
0.68 millimeters. That's barely wider than the nerve itself.
Think of it like a fiber optic cable threaded through a drinking straw that is exactly the same size as the cable.
So there's no wiggle room at all.
Zero. And that's the problem. If the nerve gets inflamed, say, from a virus like herpes zoster, which causes Bell's palsy, it swells up.
And it has nowhere to expand.
Nowhere. It strangles itself against the bony wall. That's why Bell's palsy causes paralysis. It's essentially a compartment syndrome happening inside that tiny bony tunnel.
That makes me claustrophobic just thinking about it. Okay, so assuming it survives the squeeze, it makes a sharp turn, the genu, and enters the tympanic
A
segment.
horizontal segment.
Okay.
This one's right through the middle ear, right over the stapes most. It's about 11 millimeters long.
And the notes point out a specific vulnerability here, congenital dehiscence.
This is a huge one. Dehiscence just means a gap, a failure to close. Remember how we said the bone forms from different centers?
Yeah.
Well, in this segment, the bone covering the nerve comes from 2 different origins, the audicapsule and the second branchial arch. They have to fuse to create a roof over the nerve.
Sometimes they just don't meet.
Sometimes they don't, and you end up with a nerve with no roof. The raw nerve sheath is just exposed directly to the middle ear space.
Wait, the middle ear space is where we get ear infections. It's where pus and bacteria hang out.
Exactly. That is the design flaw. If you have a child with a dehiscence, and it's surprisingly common, and they get an ear infection, acute otitis media.
The bacteria are sitting right on the nerve.
The bacteria and all the inflammatory toxins are bathing the facial nerve directly.
So the kid comes in with an earache, and suddenly their face stops moving.
Right. It causes what's called suppurative neuropraxia.
Yeah.
The nerve just shuts down because it's being poisoned by the infection right next door.
So we've gone through the bottleneck, we've gone through the exposed roof, now we hit the second knee and go down the mastoid segment.
Vertical segment. It drops straight down, 13 millimeters to the exit door, the stylomastoid foramen.
The notes mention landmarks here again. If I'm a surgeon working in the middle ear, how do I avoid hitting this nerve, especially if it might have a gap in its roof?
You memorize the triangulation points.
Yeah.
You never look for the nerve directly unless you absolutely have to. You find the cochleariform process, the nerve is always just above and medial to it.
Yeah.
You find the oval window, nerve is superior to it. You find the pyramidal eminence, the nerve is behind it.
It's navigation by triangulation.
It's the only way to stay safe.
But sometimes, despite all that, things go wrong. Or the disease itself destroys the nerve. We talked about infection. What about cholesteatoma?
Cholesteatoma is a totally different beast. It's a skin cyst that grows in the ear, but it's destructive. It produces enzymes that literally eat bone.
So it can eat right through the fallopian canal.
It can erode the bone right off the nerve. And unlike the temporary shutdown from an infection, the pressure from a cholesteatoma can cause axonotmesis,
Which is?
actual death of the nerve fibers. The internal structure of the wire is broken.
When a patient comes in with this, say half their face is paralyzed, how do you measure it? I'm guessing it looks droopy isn't the scientific term.
No, we need precision. We use the House-Brackman scale. It's the universal language for facial nerve function.
It goes from grade F to grade 6. Grade 1 is normal, grade 6 is total paralysis. That's easy enough. But looking at the breakdown, the real drama seems to be in the middle, specifically the line between grade 3 and grade 3.
You've spotted the single most clinically important line. So grade 3 is moderate dysfunction. The face is obviously weak. It looks asymmetrical. And this is the key. The patient can still physically close their eye completely if they try really hard.
And grade 4.
Moderately severe. The key there is incomplete eye closure.
Why is that the tipping point? Why does eye closure matter so much?
Because the eye is a ticking clock. If you cannot close your eyelid, your cornea is exposed to air 24/7. It dries out. It ulcerates. You can go blind.
So grade 4 isn't just your face looks a bit worse, it's your actual eye is in danger.
Exactly. At grade 4, we have to intervene immediately to protect the eye. Tape, weights, sometimes surgery. Grade 3, we can afford to wait and watch. Grade 4 changes the entire management plan instantly.
That puts a lot of weight on a simple number. Now, what if the worst happens? The nerve is cut, maybe during surgery, maybe from trauma. The notes discuss repair options. It seems like we have to cannibalize other parts of the body.
We have to rob Peter to pay Paul. You can't just stretch the nerve ends together if there's a gap. It would be under too much tension. So we need what's called a cable graft.
Where do you get a spare nerve?
2 main spots. The sural nerve from the leg is a common one, but for ear surgeons, the favorite is the greater auricular nerve.
Because it's right in the neighborhood.
It's right there in the neck, in the same surgical field.
The notes have a very specific how-to on finding this nerve. It says to draw a line.
Yeah, it's geometry again. You visualize a line from the mastoid tip down to the angle of the mandible, the corner of your jaw.
Okay.
The greater auricular nerve runs perpendicular to that line, right in the middle. It's sitting just under the platysma muscle.
So you slice the neck, grab the sensory nerve, and splice it into the face. But does it work? Does the patient smile again?
They do, but it's never going to be perfect.
Yeah.
It's never great eye again. But you can get tone back, you can get symmetry at rest, and most importantly, you can get eye closure back.
It really just highlights how precious that original wiring is. You can patch it, but you really can't replace it.
No. Once that original architecture is broken, we are just doing damage control.
So bringing this all together, we started by calling the temporal bone a piece of architectural engineering.
And I stand by that.
It really feels like a structure where the blueprints determine the destiny. I mean, think about it. You have a tiny dehiscence, a gap in the bone you were born with. A simple ear infection can paralyze your face.
Right. If you have a narrow labyrinthine segment, just a fraction of a millimeter too tight, a common cold virus gives you Bell's palsy.
It's structural determinism. Your personal anatomy dictates your entire risk profile.
And that House-Brackman scale, it's so fascinating because it translates that anatomy into humanity. It's not just measuring muscles. It's measuring the ability to communicate, to be understood, to safeguard your own vision.
It is. The face is how we interface with the world. And when that interface breaks, the isolation is absolutely profound.
I want to leave everyone with a thought that brings us back to Whitmack. We talked about his theory that a single swallow of amniotic fluid at birth could scar the ear and stop the bone from developing its air cells.
The butterfly effect of an animal.
Exactly. It just makes you wonder how many other parts of us, parts we think of as just genetic or how we were built, were actually shaped by some random tiny event in the first 5 minutes of our lives.
It's a humbling thought, isn't it? We are the sum of our genetics, yes, but also of our history, even the history we don't remember. On that note, check your landmarks, protect your facial nerve, and we'll see you in the next deep dive. Thanks for listening.